Now, it's a great honor for me to be a moderator today for a great two speaks for Dr. John and Dr. Yasser Rida. And that is a great lecture as we usually have before. Dr. John has come to Egypt before, and I have attended her lectures before, and it's a pleasure for me to introduce Dr. Doyle. Is with the Department of General Anesthesiology at Clinic College of Medicine of Case Western Reserve University. Dr. Doyle received his MD degree in 1982 and PhD degree in biochemical engineering in 1986, both from University of Toronto. He received the Canadian Board of Certificate in Anesthesia, FRCPC, in 1986, and his American certificate in 1988. Dr. Doyle has a long-standing interest in ENT anesthesia and difficult airway management, as well as an interest in the use of technology in medicine. His research has been supported by a number of funding agencies and hold his position as one of a member of additional boards. Dr. Doyle is the past president of both the Society of Airway Management and Society for Technology and Anesthesia. He had received the Clinical Teaching Award on 4 occasions. Dr. Doyle, I have attended for him many lectures in Egypt before in Cairo. One of them was the program of Gazman. He is a very wonderful lecturer, and he's a very pioneer. And we are listening for him now. Please, everybody have to mute his microphone, and we are going to listen for Dr. John Doyle. Any questions after the session will be done. Thank you, Dr. Doyle.
Hello. Thank you, everyone, for the kind invitation to speak today. My topic is tracheal extubation, examining best practices. And the foci that I have, the two approaches that I want to discuss are extubation in the operating room, as well as extubation in the intensive care unit, both for regular patients and for patients who have some sort of pathology that can make it challenging. The objectives today: to understand how tracheal extubation can be perilous, to understand the role of sedation in improving the success rate of tracheal extubation in difficult cases, particularly, for example, in patients who have been ventilated for a long time in the intensive care unit, or patients where excessive coughing can be result in problems in the operating room, such as some of the ENT cases or thyroid surgery, as an example. And we want to discuss how drugs can be a useful agent in facilitating tracheal extubation, but also taking a look at the various criteria for tracheal extubation that have been proposed in the literature. So I want to begin with some definitions: intubation, weaning, and extubation. Talk about weaning criteria that is sometimes used in the ICU, extubation protocols and algorithms that have now arisen in the published literature, and then a concept about extubation styles, the careful extubation versus the cowboy approach that I'll discuss in more detail. We do know that sedation is widely used in anesthesia and intensive care medicine for procedural sedation, for ICU sedation. But what I also want to introduce is the idea that it can be used to facilitate extubation in anxious or agitated patients, or in some cases, in ENT cases where coughing can be problematic in increasing the likelihood of bleeding. Some definitions: intubation, weaning, extubation, and self-extubation we'll have a chance to take a look at. Intubation we're already quite familiar with, and it's just included here for completion. But many people know and studied this in their early days of anesthesia and ICU training about extubation weaning criteria. Some people recommend that its ability to generate a vital capacity, typically 10 to 15 mLs per kilogram. The minimum required volume is usually in the range of 1,000 mLs in adults. Other criteria a spontaneous respiratory force of at least 20 centimeters of water, an arterial oxygen concentration more than 60 millimeters of mercury tension with an FiO2 under 40%. So these are all examples of the kinds of things that are sometimes used, often in the context of baseline measurements for vital capacity, respiratory rate, resting tidal volume, minute ventilation, arterial blood gas values, particularly oxygenation and carbon dioxide levels, and the FiO2 fraction of inspired oxygen required to achieve this. So these are examples of criteria for weaning. They vary around the world according to what protocols are used, but they have a lot of common elements. So let's talk about extubation and focus on that. Before extubation is considered, you want to do some planning. You want to ensure that the proper equipment is available. You'll want to monitor blood pressure, heart rate, saturation, respiratory rate, etc. You'll want to ensure full reversal of paralytics, and if rocuronium is the drug that is used in this setting, sometimes sugammadex is used to ensure full reversal. And in addition, train of four monitoring that's quantitative, that allows for one to estimate the train of four ratio, can be very useful, because as a rule, we want the train of four ratio to be over 90%. 90 or more percent for the train of four ratio when you reverse neuromuscular blockade. And for this, you need quantitative monitoring of the degree of neuromuscular blockade. And then there is a role for gentle sedation during extubation in some cases. We call this pharmacologically facilitated tracheal extubation. Can be used in the ICU in particular, and in the operating room as well. Sometimes we use a remifentanil infusion that's very gentle to extubate awake on remifentanil in the operating room, particularly for ENT cases like septoplasties, rhinoplasties, thyroid surgery, parathyroid surgery, and so on. Dexmedetomidine infusions can also be used, and they're particularly useful in the ICU post-extubation. Is the patient able to protect the airway? This is another question that has to be taken into account. The patient has to show an appropriate level of consciousness, demonstrate adequate airway protective reflexes, being able to cough, being able to swallow, vocal cord movement working, and secretions have to be adequately managed. So before extubation, protection of the airway is one of our goals. Can the patient pass a trial of breathing? What we can do is try a 30 to 120 minute spontaneous breathing trial with a low level of CPAP, continuous positive airway pressure, for example, 5 centimeters of water, or a low level of pressure support, such as 5 to 7 centimeters of water. You'll want to be able to also show adequate gas exchange in terms of arterial oxygen tension and arterial carbon dioxide tension, hemodynamic stability. You do not want the patient to be hypertensive and tachycardic, and subjective comfort that you can get insight into simply by examining the patient. Then there are some numbers that may or may not apply in your particular setting. Respiratory rate under 35, vital capacity more than 10 mLs per kilogram, negative inspiratory force greater than minus 20 centimeters of water, a tidal volume more than 5 mLs per kilogram, a minute ventilation less than 10 mLs per minute, 10 liters per minute, and thoracic compliance greater than 25 mLs per centimeter of water. Now, not all of these measurements will be taken all the time. Some only apply in particular settings, particularly in the ICU, but these are some examples that are frequently offered. We could put all this together with an extubation algorithm. Now, the Difficult Airway Society, which originated in the UK, has come up with some extubation guidelines, and they have a basic algorithm and then a more complex algorithm. And as you can see here, step one is to plan extubation. Study airway risk factors like a known difficult airway or obesity, obstructive sleep apnea, an aspiration risk problem. These are all things that you may want to be able to have plans for. For example, if you have obstructive sleep apnea, you may want to extubate the patient sitting up as much as possible, and you may want to assist ventilation afterwards. There's other techniques that can be used that I'll have a chance to discuss momentarily. Step two is to prepare for extubation, and for this, you want to optimize the patient make sure that, for example, adequate neuromuscular blockade has been reversed, and the patient is not hypothermic, that kind of thing. And we divide them into low risk and at-risk patients. The low risk patients are those that have an uncomplicated airway, no general risk factors, and have been fasted. At-risk patients may have uncertainty ability to oxygenate, may require high FiO2 levels during ventilation. Reintubation may be potentially difficult because of a known difficult airway, for example. So in the case of low risk patients, we have a low risk algorithm. In the case of high risk patients, we have the DAS extubation high risk algorithm or at risk algorithm. And then after extubation has been accomplished, we have post extubation care. Typically that will be in a high dependency unit or an intensive care unit, or sometimes this will take place in the operating room, and we will keep an eye on them until they are stable enough to be transferred over either to a post anesthetic care unit or a high dependency unit or elsewhere. This involves, of course, communication about what the central concerns are, what would be appropriate algorithm to carry out if the patient shows signs of failing and requires re-extubation, something that we'll talk about in a minute. So that is step 4, post-extubation care. Now, the at-risk algorithm for the DAS extubation guideline package is a little bit more complicated. You plan just as before, and you prepare as before, but the key question is it safe to remove the tube? If it's not safe to remove the tube, you have 2 choices. You can postpone extubation and then wait until they're optimized, or sometimes tracheostomy is done and you extubate with tracheostomy procedure as your backup method of managing the airway. But if it is safe to remove the tube, then you can either do ordinary awake extubation, which is just making sure they're awake and neuromuscular blockade is reversed adequately and so on, and then extubate and recover. But there are more advanced techniques that can be useful, and these I want to comment on. One advanced technique is the laryngeal mask exchange or the supraglottic airway exchange. And here what you do is you extubate, you immediately put in your supraglottic airway or laryngeal mask airway, and then you have that as your airway adjunct until they are ready for the next phase, which would be to remove the laryngeal mask airway. Another advanced technique is to run a remifentanil infusion, and this would be a low-level remifentanil infusion, 0.1 micrograms per kilogram per minute or less, so that the patient is cooperative, open their eyes to commands, for example, but when you extubate, they will not cough and sputter, particularly useful in ENT cases. And then another advanced technique is the use of an airway exchange catheter, which you place through the endotracheal tube prior to extubation. And this way, if extubation fails and they need to be reintubated, they can be reintubated over the airway exchange catheter. So this is the at-risk algorithm from the Difficult Airway Society. And of all of the images that I offer you in the slide set, this is clearly the most important in summarizing how the at-risk patient is handled. One problem we have in the real world is self-extubation. A patient like this in the intensive care unit who gets agitated and then pulls out the endotracheal tube inadvertently because they are agitated. And this is relatively frequent. As you can see in this particular illustration, in this photograph, the endotracheal tube is well secured with a harness, but that's not always the case. Sometimes they're merely taped in place, and then extubation by the patient is far more common, particularly if they are undersedated and agitated. So how to prevent self-extubation? Inadequate sedation can place critically ill patients in danger of self-injury from self-extubation. Critical care nurses can use clinical protocols to help manage agitation in intubated patients and thus prevent self-extubation. Not infrequently, this would be done with, as an example, a dexmedetomidine infusion in the period around extubation or in the period in the ICU. Another technique is extubation following placement of a reintubation catheter. And here is an illustration of such a catheter. It's an airway exchange catheter. And as you can see, there are markings on it that allow you to tell how deep you are. And then there is a 15mm connector that you can use to assist with ventilation, as well as holes at the end, which allow oxygen to be delivered to the patient, should that be necessary. And once the tube is out and the reintubation catheter is placed, you can reintubate over that by taking off the 15mm connector at the end. Here is an example of a patient from the literature. This is from critical care medicine, and it shows the routine use of a pediatric airway exchange catheter after extubation in an adult who's undergone maxillofacial or major head and neck surgery. So these are two different patients with two different kinds of surgical procedures. In both cases, they have an airway exchange catheter in place that you could intubate over. So this would facilitate nasal intubation in both these patients. You can also place it orally in appropriate patients and intubate through the reintubation catheter orally where appropriate. Now I want to talk about extubation styles. The first is what is sometimes called cowboy extubation, where you just go with it and hope for the best. Then there's pharmacologically facilitated extubation. And I mentioned remifentanil and I mentioned dexmedetomidine as two drugs that can be useful in this setting. And finally, I've also mentioned extubation following placement of a reintubation catheter. So let's take a look at these three approaches. One of the problems here is that you can get an intubation agitation style or cycle when you just extubate inappropriately. So for example, in the upper left here, we say, is there a reason to suspect that the patient has respiratory insufficiency, such as a normal chest x-ray, respiratory failure, requires high FiO2? If not, that's not the case, you can extubate immediately, you stop the sedation, and you extubate when the patient gets agitated. But more commonly, what we want to do is have a more controlled extubation. We don't want to wait until the patient gets agitated. We want to extubate earlier than that. Dexmedetomidine or remifentanil facilitated extubation can be useful. We do the spontaneous breathing trial as before, and if they pass that, we extubate and then wean off the dexmedetomidine or remifentanil. If the patient fails, you got to figure out why. A chest x-ray and chest ultrasound will detect such things as a pneumothorax, and you treat any pulmonary problem that occurs. So if the patient has been intubated for agitation and agitated from intubation, we want to take into account that pharmacologic assisted extubation can be useful. So let's take a look at more at the cowboy tracheal extubation. We stop the ICU sedation and no attempt at a spontaneous breathing trial. Extubate when the patient becomes agitated. If the agitation persists, try titrated medications like haloperidol, benzodiazepines, dexmedetomidine. And skipping the spontaneous breathing trial could be a problem if the patient wasn't ready for extubation. So the cowboy tracheal extubation approach is something that's generally undesirable, except in your most straightforward healthy patients. For pharmacologically facilitated tracheal extubation, we use remifentanil, dexmedetomidine, or other agent to create a sedative bridge from intubation to extubation, avoiding agitation throughout the entire process. As I said before, with remifentanil, we'll often run 0.1 micrograms per kilogram per minute, titrate down. And then when the patient is cooperative, opening his or her eyes to command, and we have adequate tidal volumes, then we extubate on low-level remifentanil. Sometimes we just turn off the remifentanil and wait until we get exactly the right level of consciousness for the patient, right cooperation to extubate there. With dexmedetomidine, typically they will have already received a loading dose of 1 microgram per kilogram for healthy patients and somewhat less for the fragile and elderly, and then run an infusion of 0.2 to 0.7 micrograms per kilogram per hour. And note that dexmedetomidine is given in micrograms per kilogram per hour, not micrograms per kilogram per minute, which is frequently done for almost all other drugs. This technique incorporates a spontaneous breathing trial. We want to look at our tidal volumes, minute ventilation, and so on. And we extubate when the extubation criteria is met. And then we wean our remifentanil or dexmedetomidine or other sedative post-extubation. What about extubation assessment in the ICU? How do we establish extubation readiness? Well, remember that ventilator weaning and extubating are two separate processes. Identifying patients for extubation based solely on your clinical impression can be inaccurate. Predicting patient readiness is based on a number of physiologic variables. No single parameter can accurately predict which patients are ready to resume spontaneous breathing. But things we often look at are tidal volumes, minute ventilation, arterial blood gas data, and degree to which the patient is awake. So here are some sample weaning criteria that are used in some centers around the world: vital capacity, inspiratory force, respiratory rate. Particularly, you're worried about the patient who's tachypnic. Arterial blood gases, we're worried about a patient who's hypoxemic or hypercarbic, or patients that require high levels of FiO2. So these are weaning criteria that we're already familiar with. Here is more information about possible weaning criteria. Remember that no weaning parameter accurately and completely identifies which patients can be extubated, but here are some clinical parameters: hemodynamically stable, intact cough reflex, they have an intact gag reflex, they're breathing spontaneously. The ventilator settings showing PEEP under 8, FiO2 under 50%, PaO2 over 75, pH greater than 7.25. And general approaches can be SIMV weaning, pressure support ventilation weaning, and spontaneous breathing trials. Those people that like numeric methods, we have tidal volumes. For example, you want it between 5 and 7 mLs per kilogram, respiratory rate 14 to 18, vital capacity, normal range 65 to 75. You may get some patients who are sick, who don't meet the normal range, and you may, for example, have patients whose tidal volume is less than 5 mLs per kilogram, respiratory rate that may be excessive, and these patients require special consideration if you are planning to extubate, and you must have a plan to reintubate under these settings. So here is an example of a failure. Proposed criteria for failure during 2 hours of continuous positive airway pressure at 5 centimeters of water PEEP, or on a T-piece with 0 end expiratory pressure. If the patient demonstrates increasing respiratory effort, if the patient demonstrates tachycardia, heart rate increase more than 40, cardiac arrhythmias, hypotension, apnea, diaphoresis. These are all clinical criteria showing failure. And then increase in end-tidal CO2 over 10 millimeters of mercury, decrease of arterial pH under 7.32, decline of arterial pH greater than 0.07. These are all examples of imminent failure for 2 hours on CPAP. And this is just an example of one set of criteria that is proposed in the literature. But remember, failure is a bruise and not a tattoo. You can recover from failure. In the case of failed extubation, reintubation is always an option. Other things to consider are the use of BiPAP and CPAP for these patients. So let's take a look at extubation assessment in the ICU, determine disease resolution, and consider other factors. For example, if the patient is overloaded, can you diurese them? Identify candidates for spontaneous breathing trials, perform a spontaneous breathing trial, identify candidates for extubation, and then extubate and provide post-extubation care. So that's the approach in the ICU. And that brings an end to the discussion here. Our focus has been on a systematic approach to extubation in the operating room and in the intensive care unit. I mentioned earlier that perhaps the most important message here is that there is a difficult airway society extubation algorithm that has been recommended and that I'll bring to your attention. You can simply Google it. and get more information. In addition, there is quite a bit of peer-reviewed literature out there that you may want to consult, but I would argue that the best place to begin is with the DAS algorithm. Thank you very much for your time.
Thank you for Dr. John very much. It's a very good lecture. Already, and you are professor in airway management. Any questions? I have a question for myself, please. Dr. John?
Hello, you had a question?
Yes, I have a question.
Sure.
About airway exchange. Is it well tolerated for barge patient, or it gives a guide wire instead of airway exchange catheter, and then proceed an airway exchange catheter over the guide wire, or the airway exchange catheter?
The question was, how do you use the airway exchange catheter?
Enough and produce no stress response.
So if I understand,
airway exchange catheter, is it well tolerated? Well tolerated by the patient?
So here, as I understand your question, because unfortunately the message was kind of being broken up, and I didn't receive it that well. But if I understand the question, it's about the use of the airway exchange catheter. And the airway exchange catheter is inserted just prior to extubation, inserted into the endotracheal tube. It goes into the endotracheal tube, and then the endotracheal tube is removed over the airway exchange catheter and taped in place. There are markings on the airway exchange catheter so that you can be sure that you are not too deep, because you don't want to be touching the carina. And then you keep an eye on the patient's spontaneous breathing to ensure that they are not failing. But if it is clear that they are failing and they require reintubation, what is done is an endotracheal tube is passed again over the guide wire, which is, it's not really a guide wire so much as it's an exchange catheter, and you can actually pass oxygen through it that can be helpful to ensure oxygenation in the patient. And then when you pass the tube over the exchange catheter, you remove the exchange catheter and inflate the cuff and resume ventilation. So that's how that is used. And there's a number of articles, including some YouTube videos demonstrating that technique.
Yes. Thank you very much, Dr. John. It was a very good lecture. And I think there is no more questions for this lecture. And all the questions will be asked after the.
Okay, thank you very much.
Okay. Thank you very much. Now for the second.